to our webinar entitled Preventing Falls in the Ophthalmic Office and OR. My name is Menke. I'm OMIC's Patient Safety Manager and have no financial disclosures. In this course, I'm going to present 4 case studies. In between them, I'm going to present the results of a study I did on OMIC claims after patients fell. After I present information, I'm going to give you a moment to think about the best way to handle the situation in your practice. I'm also going to make you the experts in the case. And after each case, I want you to think about whether the ophthalmologist and staff met the standard of care. If you feel they did, the defendant should be dismissed. If not, the plaintiff should be compensated. I'll be presenting more information as each case progresses. And as the new information is available, think about whether this changes your opinion. First, let me explain a little bit more about medical malpractice. We talk about the 4 Ds. The first D is the duty of the physician to treat the patient. Once a physician-patient relationship is established, the physician has the duty to provide ongoing care and care that meets the standard for that profession. This requires expert testimony under oath in each case, and usually the standard in each state is what would a reasonably prudent ophthalmologist do in the same or similar circumstances. The third D is a direct causal relationship between what the physician or staff did or didn't do and the alleged injury or damages. This is also called the proximate cause. This is important because even if there was negligence, if the patient would have sustained the injury anyway, then you can't vote that the physician was negligent. The final element was damages, and these are both economic and non-economic. Economic damages include past and future medical expenses and lost wages. Non-economic damages are often called pain and suffering. If we make a payment, it's called an indemnity payment. So let's look at the first case. This involves a 73-year-old woman who presented for an eye exam. She was asked to sit on a stool. She slipped off the stool and landed on her tailbone and went to the emergency room where an X-ray showed a possible hairline spine fracture. So, should the physician or staff have prevented this fall? Was there any way they should have anticipated that the patient would have problems? What we learned during the investigation. This patient had significant medical problems, including the need for regular blood transfusions. Most importantly, the stool had wheels, and no one helped her while she was sitting down to make sure the stool didn't go out from under her. Does this change your opinion? For most people, it would, because the patient was frail, the stool had wheels, and she obviously should have been assisted. The patient had significant pain and never walked again. In fact, she died 9 months later. This might not change your opinion on whether the standard of care was met, but it might change your opinion on how much compensation this plaintiff's family was entitled to. This case settled for only $60,000. When patients die, there are no future medical expenses, and this patient was already retired, and so there were never any lost wage claims, so the lawsuit settlement was not high. The most important message I want you to hear is that falls change lives. They're the leading cause of fatal and non-fatal injuries for people 65 and older, according to the CDC. They compound the burden of pre-existing health problems and can precipitate an inexorable decline. In fact, 20% of patients die in 1 year of the fall, as the patient in our first case did. Falls can be caused by patient characteristics such as age, health problems, or medications such as those that can lower blood pressure too far. Or the floor can be wet, the lighting can be poor, or the stool can have wheels. Who's to blame when a patient falls? Many falls happen at home. When they happen in a physician's office or ambulatory surgery center, many patients and their families believe the healthcare team should have predicted the fall and prevented it, and they thus file a malpractice lawsuit. I looked at OMIC claims from patients who fell between 1987 and 2015. Only 41 patients filed claims, but they filed them against 50 providers. There are more claims than patients because they may sue more than one person. They may sue, for example, the physician and the surgery center. These were only 1% of OMIC's total claims. Most of the patients were older than 60 years. It's important to know that many more patients fell, but they didn't sue the ophthalmologist or surgery center. Often when a patient falls, the practice will offer to pay for the emergency room visit or any care needed to address the injury, and that can prevent a lawsuit. My study showed that the fall had a severe impact on the plaintiffs. 4 patients died, 3 within the first year. Almost every single one of them had significant injuries, so none of these were nuisance lawsuits. 25 had fractures, and if you look, there were fractures on pretty much every part of the patient's body. Others had rotator cuff tears or serious soft tissue injuries. Let's look at the second case. This was a 79-year-old woman also presenting for an eye exam. Her eyes were dilated, and she fell after leaving the office and sustained a hip fracture. Was a standard of care met? As you could tell from the first case, we need to know a little bit more about this patient to know if she was obviously at risk of falling. This patient had no known health issues. She had had her eyes dilated before. As per the protocol, the staff members offered her sunglasses because they know that the bright light can cause vision problems. She exited after leaving the dark office into the sunlight, and she didn't have sunglasses on because she declined the offer. She lost her balance on the stairs and fell. How does this information change your opinion? Well, our defense attorney decided to inspect the premises and noticed that the first step was 8 feet from the door and that there were handrails on both sides and down the middle of the stairs. So the patient didn't immediately have to descend the stairs, and there are plenty of handrails to hold on to. Each step was 3 feet long, and the edge was painted in black to help it stand out. The defense attorney concluded that these steps were constructed as safely as possible and in good condition. He also felt that even if the patient were temporarily blinded by bright sunlight, as she claimed, she had space and time to allow her eyes to adjust before starting down the stairs. He filed a motion for a summary defense judgment, which means that the case was heard by a judge, not a jury. It's important to know that the plaintiff never found any expert willing to criticize the physician or the staff, and that this was a healthy patient who knew what to expect after dilation. And most importantly, she had declined the offer of sunglasses. The judge granted the motion for summary judgment, and the case was dismissed. So there are 2 types of allegations that can be made in lawsuits after a fall. One is that the premises wasn't in good condition. That's usually means that a general liability policy would respond to this type of lawsuit. Or the lawsuit should claim that there was a breach in the standard of care in the performance of healthcare services. This would then be a professional liability lawsuit. Some questions to answer is, was the patient receiving medical care at the time of the injury? Did the services require special knowledge, licensing, or accreditation? If those are yeses, then it's more likely to be a professional liability claim. Was the patient in the waiting room or already in the exam room or the operating room? It's more likely to be considered a general liability claim if the patient was still in the waiting room, especially if the patient hadn't received any medications. Was there an equipment malfunction? Was there a failure to supervise or secure the plaintiff? There are other key differences. Medical malpractice or professional liability lawsuits tend to have a longer statute of limitations because the harm may not be immediately obvious. There's also a need for experts because juries need help understanding the medicine. Sometimes claims have to be vetted by a medical review panel before they can proceed to lawsuits. Damages may or may not be capped, and most importantly, different insurance policies are available. We recommend that to protect yourself and your practice, you report the fall to both your professional liability carrier, i.e. OMIC, and your general liability carrier. Sometimes both will decline the case, sometimes both will respond, but that way you've got the best chance of getting help. Let's go on to the third case. This was a 90-year-old patient who presented again for a dilated eye exam. This patient began to get up from the exam chair, scuffed her shoe on the floor, twisted and fell to the ground. The tech caught her upper body as she was falling and was able to protect her head from injury. The physician entered the room, and the patient said to him that she had lost her balance or something. She started complaining of right hip pain, was assisted into a wheelchair, and taken to the car where her daughter was waiting. Although the ophthalmologist encouraged her to go to the emergency room, she said she didn't want to, and even at the hospital told the physician she didn't want any care. That physician advised her to use Tylenol for the pain and to call her primary care physician if the pain persisted. The next day, she felt much worse and was taken by ambulance back to the emergency room. We hired an orthopedic surgeon as an expert. He noticed that the patient had a non-displaced subcapital right hip fracture, so she did sustain, again, a serious injury. However, he also noted she had screws in her left hip, showing that prior left hip fracture that had been surgically corrected. He also noticed moderate to advanced degenerative joint disease. The patient underwent surgery and spent 45 days in a convalescent hospital. She had persistent occasional right hip pain after her surgery. So, was the standard of care met with this patient? Should something have been done differently? The orthopedic surgeon we hired opined that the patient had a spontaneous or indirect traumatic hip fracture, which caused her fall. He felt that the tech would never have been able to prevent it, and in fact praised the tech for doing such a good job of breaking the fall and preventing serious injury to her head. How does this impact your sense of how the practice did? The plaintiff testified that she was blinded by the dilated eye exam and that she had called out for assistance, but the tech didn't respond, so she started getting up on her own. She claimed that the tech had a duty to stay with her and provide assistance until she was out of the building. This was a very plaintiff-friendly venue, which means that juries are most likely to award money. We also felt that the verdict could be high, so we decided to take this case to mediation, which means both sides present their case to an attorney who then makes a decision. As a result, there was a $100,000 settlement. Both the ophthalmology practices carrier, OMIC, and the GL carrier paid $50,000. The physician was dismissed from the case because he wasn't even in the room when it happened, so this case was settled on behalf of the practice. Where did patients fall? Most of them fell during or just after office visits, and 11 fell in a surgery center. Let's look at those intrinsic risk factors for falls. And remember, these are things related to the patient's own medical condition. As I mentioned earlier, most of the patients were older. Half of them almost had dilating drops. 8 of them already were using a wheelchair or cane. 8 fell right after surgery. 5 had significant health issues, and 3 had a history of falling. What were they doing right before the fall? 12 were trying to sit down or move. The next in frequency was moving from dark to light, as in the previous case. 6 were trying to stand up from a seated position. 4 were transferring to or from a wheelchair. 3 younger patients had a vasovagal reaction to the procedure. They fainted. 3 were walking in the office or the parking lot when they fell. 2 were using the restroom, and 1 fell because of faulty equipment. Let's talk more about dilating drops. These are essential to the diagnostic process. In fact, it would be considered below the standard of care if the ophthalmologist didn't dilate the patient's eyes before an exam. We know these can cause temporary vision problems such as light sensitivity, glare, and decreased contrast sensitivity. Dilating drops cause more problems for older patients because it takes longer for their eyes to adjust when going from a dark office to a bright outdoor setting. 10 of them fell moving from the office to outdoors, and some of them were wearing sunglasses when they fell. Physicians have a duty to warn patients about the side effects of dilating drops. They can impact moving. They can impact your driving. If you're not seeing well, you can cause a motor vehicle accident, and patients can sue after that. And as we've seen in this study, they can cause falls. The physician could be sued for harm to the patient or others if the patient wasn't warned about dilating drops. They have to be warned each time their eyes are dilated, and you need to document the warning each time. I go back a second. Usually these drops are administered by staff members, and you can use either a chart stamp if you're one of the minority of practices still using paper records, or you can have a statement in your electronic medical records that states that the patient was warned about the impact on driving or walking after the drops. What about the risks of standing up? Again, older patients are at higher risk. They can experience a drop in blood pressure and feel faint, and this drop can be more easily induced if they're on medications to control their blood pressure. They're especially vulnerable after sedation or anesthesia. They often don't have strong muscles in their abdomen and legs, and you can tell if that's the case if you see them using their hands to push off from a chair or to stand up. Let's go on to another case. This was an 82-year-old woman. She fell when asked to move onto a chair with wheels. The chair went out from under her, and she fractured her hip. You know this story. It's very similar to the other ones, and as you might anticipate, experts are going to be critical. Both the plaintiff and defense experts criticized the use of stools or chairs with wheels. They both felt that if these are used, the patient should never be left unattended, especially older patients. This required surgery, extensive hospitalization, and care in a nursing home, and incurred $100,000 in medical expenses. We were surprised when we learned that Medicare refused to pay for that $100,000 when they learned how the fracture occurred. So this case settled for $235,000 and was the highest payment in the lawsuit. So what did we have to pay to settle claims? Lawsuits filed after patients fell needed payments to close in 39% of the cases. This is about twice as often as OMIC's overall claims. You can see, however, the range of payments is significantly lower, as is the average and middle payment. There is, as I mentioned, a high settlement rate, and the physicians and surgery centers often decided to settle quickly when the claims involved severe injuries, obviously frail patients, or patients who had canes, walkers, or wheelchairs, and so obviously needed help ambulating. Physicians were named as defendants, but the falls usually occurred when the patient was alone with staff, and so the physician was then dismissed from the lawsuit, and the settlement was made on behalf of the practice or surgery center. When physicians are involved in a payment, that has to be reported to the National Practitioner Data Bank, but no report is required when a practice or surgery center makes the payment. The most important thing to do, obviously, based on these patient examples, is to identify, if you can, patients who are at risk for falling. The CDC noted a high number of older patients are injured each year in falls, and they developed a program called STEADY, Stopping Elderly Accidents, Deaths, and Injuries. The materials that they've prepared are geared to primary care physicians who can assess the patient's strength, balance, and conduct mobility tests. The CDC recommends that you ask a few questions to determine if the patient is at risk. The CDC questions are the first three, and a surgery center involved in one of the lawsuits added the fourth. So here's the quickest way to identify someone who's at risk of a fall. Have you fallen in the last year? Do you feel unsteady when you stand up or walk? Do you worry about falling? Are you dizzy or lightheaded sometimes? If the patient says yes, provide assistance and let the whole team know. The CDC questions would have identified 19 of the 41 patients as being at high risk, and the ASC question would have identified additional patients, especially younger ones, who are likely to have a vasovagal response. How do you determine if the patient has gait or balance problems? If you see any of these things, you should go to the patient and provide help. Are they using their hands to push up off of a chair? This is a sign of abdominal or leg weakness. Are they holding on to furniture while walking around in your office? This could indicate a fear of falling or weak extremities. Do they have trouble stepping up to the curb? This could indicate poor depth perception or muscular problems. Patients need help if they're going to use the restroom and are frail or at risk of falling. And they may rush to get to the restroom because many of them have urinary urgency. Any patient who uses a mobility aid, such as a cane, walker, or wheelchair, is at risk of falling. We recommend that you offer assistance to all of these patients, but some of them may decline your help, and you need to respect that choice, but stay very close to the patient at all times and be prepared to help. This was one of the most interesting things I learned doing this study, was that patients who are sad or depressed are at increased risk of falling. Perhaps they're less attentive to their environment, they don't notice obstacles or steps. So ask a patient if they have been sad or depressed in the last several weeks. If a patient reports dizziness or lightheadedness, provide help to them. So what did the experts say about who needs assistance? The experts for the patient said that each patient should be escorted to the front desk after dilation and escorted to their cars. Defense experts disagreed, in part. They felt that if patients function normally outside the office, they should still be able to function normally outside the office, even if their eyes are dilated. It's helpful to educate your patients about the risk of falling. You could place signs in your lobby or exam lanes that say, "Stand up slowly," or "Stand still a minute after you stand up." Patients who are near the exit should be reminded to take your time. Wait for your eyes to adjust. You may be wondering about what kind of assistance you should provide when moving patients. We know that the healthcare industry has some of the highest reports of injuries from overexertion. The risk factors are manual lifting, moving patients, and repositioning patients. And many of these injuries don't heal. The CDC concludes that there is no safe way to manually lift another human being. If a patient needs to be lifted, you should use a mechanical equipment, not staff. Ophthalmology offices aren't going to have this equipment, so patients who need to be lifted should be sent to a facility that has the necessary equipment. If you have follow-up questions about this talk or about patients who have fallen or who may be at risk of falling, please contact our risk management hotline. There's the email address and how to call us. There are also many other resources available on our website. Thank you so much for listening to this program. I hope it was helpful.